Good afternoon, everyone. Thank you for joining the MAC meeting at 4 o'clock today. It is a different start time than normal. If you are a committee member, if you would put your name in the chat. If you are a committee member who's on the phone, if you would unmute and let us know that you are here. And Michael, we do have a quorum, so you can start at any time. Thank you very much.
Okay. Thank you, Sharon, and welcome to all who've joined us today. We know we have a lot of visitors and many who will be presenting, and we thank you for your preparation, and we'll look forward to hearing what you have to say. First, let's go ahead and approve our meeting minutes from our last meeting from April. I'll entertain any motions from the committee to approve.
I'll make a motion to approve the April minutes.
Okay,
and I'll second that. And this is Jennifer Brinton. I'm unfortunately on a phone call. I couldn't like go into the meet, so just letting you guys know I'm here. So.
Okay, thank you. All right, and as usual, we'll just vote by silence unless anybody opposes that motion. We'll consider the meeting minutes from last month approved. Okay, thank you. One other item of business we have is that Emily Zeitlin, who's been on the MAC, has resigned her position, and she's decided to go back to the Midwest to pursue some additional education. So we have an additional opening for a consumer representative to participate on the MAC going forward. So if you or anyone else you know are interested in fulfilling that position, if you'll please contact Sharon and let her know of your interest, and she'll get some background information so the agency can consider a nomination. Okay, with that, our first item today is a brief overview of an amendment to an 1115 waiver. So Laura, we'll turn it over to you for presentation of that.
Great, thank you, Michael. We have a new 1115 waiver amendment to present today, health-related social needs. I will review the amendment summary that you have all received, and in the interest of time, since we have a packed agenda, I will try to read through it quickly as quickly as possible and then open it up for comments. I won't take the time to review some of the detail that's included in the summary, but the full amendment is available on the 1115 waiver website, and the URL is listed on the summary document, and I will also drop it in the chat. To note, today is the first day of the 30-day public comment period, so you can also provide comments through the website, and there's a link to the comment form on the main page, or you can send through the 1115 waiver email address, which I will also drop in the chat, or through mail. And you can provide comments through June 15th. So I will go ahead now and review the summary. So health-related social needs. With this amendment, the state is requesting authority to provide a defined set of HRSN services to individuals who meet qualifying criteria. These services include provide medical respite care to qualified adult expansion Medicaid and targeted adult Medicaid members, expand housing-related social services benefits to qualified Medicaid members who, within the previous 12 months, were inmates of a correctional facility and received justice-involved reentry services through Utah's demonstration waiver. We do have a couple of additional change requests. The first is that we are requesting that all housing-related service and supports benefits for TAM members be provided under this current demonstration request. And then we're also requesting a change to our fertility preservation for individuals diagnosed with cancer eligibility requirements that is outlined in the STCs. We are asking that the beneficiary age be changed from 40 years to younger than 50 years of age. As far as the eligibility goes, the housing-related services and supports for recently incarcerated individuals and individuals eligible under this benefit must be a qualified Medicaid member, and within the previous 12 months, the individual must have been an inmate of a correctional facility must have received pre-release services through Utah's demonstration waiver. A correctional facility includes a state prison or county jail and does not include federal prisons. The individual must be experiencing homelessness, housing insecurity, or interpersonal violence and trauma. And the individual must meet one needs-based criteria and one risk factor as described in the table below. And this is where I will not take the time to read through those, but as I mentioned, you have them in your handout and they can also be found on the website. And then if we'll just go down to the proposed demonstration timeframe, we intend to implement this coverage as soon as possible after approval. And the benefits for medical respite include time-limited medical care in a stable environment, and the maximum benefit period is 40 days in a 365-day period, and that is assessed based on a rolling year. And the housing-related services and supports for recently incarcerated individuals are tenancy support services, community transition services, and supportive living services. And again, you can refer to the amendment for additional benefit details. And the population impacted, what we expect, those are listed in the table. And that is what I have to present as far as the summary goes, and we'll now open it up for comments.
Okay, it looks like we don't have any pressing comments that I'm seeing yet, Laura, but as you mentioned, people have until June 15th to submit comments to you, and we have the materials to review. So we will thank you for your presentation and then proceed with our budget public comment.
Thanks, Michael.
You. Okay, so the rest of our meeting will be spent on our public hearing for new funding requests for the state fiscal year 2026, which begins July of 2025. And we just want to be clear of the MAC's role in that process. So the presentations that will be made today will be reviewed by the MAC committee members and voted on next month in our meeting to rank a priority as an advisory piece of information to the Department of Health and Human Services as they work with the governor's budget office in putting together their proposed funding requests going into the 2025 legislative session. So that is what we are here to do today. And we appreciate all of the information that has been submitted ahead of time. So we've had a chance to look at the materials or review them after the presentations. Because of the number of presenters and issues, we're going to target 5 minutes for each presentation so that we can try and get done within the 2-hour meeting block that we have established for this meeting. So without any additional background, let's proceed with our first presentation. We have Logan Poole and Dave Moody from Novo Nordisk. If you would go ahead with your presentation.
Sure. Thank you. Hello, my name is Logan Poole, and I'm a pharmacist and an obesity medical liaison with Novo Nordisk. I want to first thank you for opening up the conversation around obesity management and anti-obesity medications. In terms of obesity prevalence, as of 2022, Utah has an adult obesity prevalence of 31% and has increased by 12% over the past 20 years. This continues to increase with the projection that nearly half of the U.S. adult population in 2030 will have overweight or obesity. The CDC recognizes childhood obesity as a serious problem in the U.S. Between 2017 and 2020, the obesity prevalence was 22.2% among adolescents. And like adults, the social determinants of health impact children and adolescents when it comes to the prevalence of obesity. Overweight and obesity increases the risk of developing many serious chronic diseases such as heart disease, stroke, type 2 diabetes, dyslipidemia, MASH, and 13 obesity-related cancers. Sustained weight loss has been shown to provide health benefits, including a reduction in cardiovascular disease and improvement in nearly 200 downstream comorbidities related to obesity. Now is the time to start helping patients with tools to help them with this serious chronic disease. Guidelines from the American Association of Clinical Endocrinologists and the American College of Endocrinology recommend lifestyle and behavioral intervention foundationally, followed by pharmacotherapy and/or surgical treatment, depending on the patient and their risk for the associated disease. I want to thank you for your time today and transition to my colleague, Dave Moody.
Thank you, Logan. My name is Dave Moody. I am Regional Lead for State Government Affairs with Novo Nordisk, covering the state of Utah. And I just wanted to update the committee. I know that we were on the agenda last year. I just wanted to really update the committee on some recent developments. And this slide is really just a brief kind of point around legislative activity that happened in March. So on March, I guess it was March 1st, the Utah legislature passed intent language for DHHS to review and analyze the efficacy of including anti-obesity medications in the Medicaid program. Next slide, please. It was last year that, in May of last year, the University of Utah College of Pharmacy published a report on weight management medications. And there were some recommendations within the report. One was the board may consider recommending that at least one weight management product, FDA approved for long-term use in adults and children 12 years or older, be preferred. And then I guess just to update the committee, there have been several states that have added anti-obesity medications within the Medicaid programs. None have discontinued coverage, but there are now 16 states across the country that cover anti-obesity medications for the Medicaid population within their states, including California, which the decision was made last year for Medicaid coverage. And then next slide, please. Well, that's a continuation of the pharmacy interview. Okay, so the Utah Medical Association passed a resolution in 2022 in support of access to obesity treatment for all Utahns. And one of the lead sponsors of the resolution, Dr. Juliana Simonetti, was obviously instrumental in that resolution, and she is our next presenter, and I'd like to turn it over to Dr. Simonetti. Thank you.
Thanks, everyone, for giving us this opportunity to talk with you today. So I am a physician trained in internal medicine, and I did additional training. I did a fellowship training in obesity medicine and clinical nutrition back in Boston over a decade ago. And I have been working on the field as an obesity medicine specialist for several years. I'm currently the co-director of the Comprehensive Weight Management Program here at the University of Utah and the medical director for the medical program here at the university. And I have been working with patients. We see several patients who have Medicaid within our clinic. And, you know, we all know that the Medicaid population have one of the highest rates of obesity along, you know, in our state. And we know that that goes with the patients with lower socioeconomic status. In addition, not only that they have higher rates of obesity, they have higher complications associated with obesity, such as more poorly controlled type 2 diabetes, heart failure. We see many patients in clinic with that. We know that fatty liver disease is become, you know, quite a pandemic now, that we are seeing many patients not only with fatty liver disease, but those that have complications from fatty liver disease ended up having cirrhosis and now needing transplant. And I see many of those patients because they need to lose weight to get enrolled in the transplant list. And the list kind of goes on, and we all know all the complications that are related to obesity. And I can tell you example after example of the patients that we see. One in particular is a patient that one of our cardiologists, Dr. Kaur, and I shared in the clinic, and we have present this patient as a case study, where he had heart failure, had a very high BMI of 62. He was a young man in his 30s with a BMI of 62, had heart failure and was retaining a lot of fluid related to his weight, had obesity-related hypoventilation, and the list kind of goes on, right? With the NASH and some fibrosis on his liver, decrease in mobility, requiring oxygen, requiring home care, and he had multiple hospitalizations. One thing he didn't have was diabetes, which is incredible for some of those patients with such high BMI. He had pre-diabetes, but not diabetes, and therefore did not qualify for GLP-1s. This patient had 5 hospitalizations with less than a year period, and some of them requiring ICU care. So each hospitalization cost a minimum of $50,000 per hospitalization, and the ones requiring ICU care much higher cost. This patient over the year cost over $1 million for Medicaid. We got an approval to use GLP-1s. We have a comprehensive approach. We have a multidisciplinary team. We got a special approval for this patient to use a GLP-1, and he had lost over 150 pounds. He's now off oxygen. Many of his medications we have been able to decrease and cut it down. He has not had 0 hospitalizations since, he was able to lose weight, overall feeling better. Many of the obesity-related complications improved. So he is a perfect example why we need to be treating this patient population. Again, I have patient after patient. I saw one this week with Down syndrome with really high BMI. Unfortunately, I'm almost hoping, it's a sad day when I said I'm hoping my patients have diabetes so I can give them access to the medications that they need, that we know to be effective. We know that these medications can be life-saving. And I can't tell you the frustration as a physician that we all face, that we cannot treat the patients that we feel that are in the most need, that we know would benefit from this medication, and we just cannot get it. And sometimes I have put in 5 appeals, and the amount of time and effort that it takes from our staff that we could be treating patients, and we are doing paperwork for something that we know is effective, that is helpful, and is life-saving for a population that truly needs this care. So I plead with all of you to take this into account and consideration in how important this is for you. It's not only the moral and the right thing to do, but I truly believe it can be cost savings, in particular when you're caring for a population in the long term. So
Okay.
I'll stop here. Thank you.
All right. Thank you, Doctor. Cassidy, you have a hand raised. Do you have a comment or question? Okay. No, Rachel?
Yeah, I apologize. I'm about to switch on my computer. So if this was part of the presentation and I just didn't see it, or if it was mentioned and you guys cut out when I was driving, I'm really sorry. Did you say exactly what medications we're talking about? Like, I have to assume that like Wegovy and like the Ozempic alikes are included. Are there any others, or am I wrong in that assumption? I'm just wondering exactly what you're asking.
Rachel, I think from my perspective, what I can tell you that a lot of the patients, because they, in particular the ones in Medicaid, they are so sick. We do have oral medications, older generation that tends to be cheaper, such as phentermine, topiramate, Contrave as being some of those options. Unfortunately, for a lot of our patients who have a lot of the complications, so they have heart complications or they have kidney and liver complications, they are not candidates for the oral agents. And the only agents that do not impact their kidneys, their liver, and like sometimes it's because of psychiatric issues, is the GLP-1s, and the newer one would be GLP and GIP, really semaglutide, knowing as Wegovy for weight loss, and the other name is Ozempic for diabetes, or medications such as Mounjaro, which is for diabetes, and tirzepatide is the generic name, and Zepbound for, I would love to have access to all the medications, but in particular those that really, that's what the most of the population, in particular those with really high complications, would need.
Okay. Thank you,
Thank
Dr.
you.
Stefanetti. We are short on time. We need to keep everyone on track. Sorry, Michael, you can go to the next one.
That's great. Thank you. And for members of the committee, let's try and hold the questions as best we can so that we can allow everyone to present, and then we can try and get some clarification later through the materials. So let's move to our second presentation. We have Emily Polichetti from the Utah Association of Music Therapists.
Hi, thank you so much for having us present to your committee today. I'm Emily Polichetti. I'm a state certified and board certified music therapist. I work at the Huntsman Mental Health Institute with the University of Utah Health System as a music therapist, and I specialize in neurologic music therapy. I am disabled myself, and I am dedicated in both my paid and unpaid work to decrease barriers to care for services for all.
And hello, I'm Emily Salisbury, another Emily, another state certified and board certified music therapist. And I'm the owner of a small music therapy practice, providing work for a small team of music therapists. We work in hospice, skilled nursing facilities, memory care, employment training facilities, and day centers for adults with developmental disabilities. And we also provide one-on-one care for children and adolescents with various socio-emotional and developmental needs. My experience is that lack of Medicaid and Medicare funding for music therapy makes it very difficult to see a patient or a group at a facility consistently enough for the therapy to be as effective as possible. Because of funding shortages, music therapists are not able to work at the full scope of their practice. There are a lot of things that we could be doing to support the well-being of those who are on Medicaid, but we have to end up declining or limiting service time and time again for clients who need our services and are unable to pay.
So music therapy has been around for over 70 years of clinical history here in the US. Music therapy is noted to be cost-effective, efficient, and a professional therapy. Music therapy offered by a board-certified music therapist addresses multiple clinical domains in one session, like communication, motor, and cognitive skills, for example, a patient with disabilities. So music therapy supports include also behavioral and psychosocial issues that sometimes present barriers, and as they're part of the care, that's something that we can address while meeting all other needs at the same time. Music therapists accomplish this in a unique way that is unmatched, but complementary to the other important related services. Next slide. The cost savings is realized for these interventions, demonstrating one way to effectively utilize taxpayer money, which we know is a primary concern at this time and all times. For example, music therapists use effective methods for decreasing pain, agitation, disruptive behaviors, which has direct implications for how much is spent on pharmaceutical interventions. Next slide.
Recently, a survey was conducted to measure the effects of music therapy practices in Utah. You can read some of the results of that survey on the full set of slides that was released prior to this meeting. In the survey, we received many positive reports of how music therapy is being used in our state, and including an example. Can you go to the next slide? An example of a client's recent experience. I've done so many types of therapy over the past few years, and while a speech therapist does more direct speech or an OT does more direct sensory, music therapy hits on everything. I work on many different things in a 30-minute session that I don't get anywhere else. I get so much out of music therapy. Next slide.
Individuals with brain injuries, disabilities, medical complexities currently receive a basic level of care that keeps them comfortable. However, what if our intent as a community was not to support basic needs and comfort, but to provide meaningful care that accelerates that progress and contributes to their well-being? A more effective service, such as music therapy, would add more value to every Medicaid dollar that's spent on additional services or all those necessary in addition to music therapy. It enables us to be more efficient with our time and our resources in Utah. Research shows that those who receive music therapy services are not only more engaged in their music therapy treatment, but they show more progress outside of that session. Here in Utah, music therapists in our community have found the following results from music therapy treatment. Patients with brain injuries improve their walking by 25 to 50% with music therapy just in the first session compared to physical therapy alone. Individuals with disabilities see huge gains in functional skills such as communication and social engagement, with averages of 20 to 25% more progress on these goal areas once music therapy is introduced. Next slide. Our request to this committee is to advocate to add music therapy to relevant waivers in order to provide a much needed, efficient, and efficable service to the people of Utah. As we advocate and hope to have a legislative sponsor for both music therapy licensure and specific inclusion on waivers, we want your support. We hope this information has been helpful as you consider the best methods for including music therapy in the state Medicaid waiver programs. Thank you for your consideration and your attention to this important matter. We welcome any questions in the future and look forward to future opportunities to discuss the benefits of music therapy. Thank you so much.
Okay, thank you, both Emilys, and we thank you for focusing on your time. Very much appreciated. Okay, next we have Haley Bennett. If you can proceed, please.
Hello, everyone. My name is Haley Bennett, and I'm from Arrowful Health. Today, I'm here to propose increasing reimbursement rates for prenatal and postnatal lactation education, CPT code S9446 by Arrowful Health. As a healthcare leader who has served nearly 1 million moms this year, we champion fair reimbursement rates for equitable access to vital preventative services, especially for maternal and infant care. Our patient education highlights the benefits of lactation, infant care, parenting, labor, and the other significances of breastfeeding. We propose a $20 rate adjustment to ensure that qualified providers receive better compensation. Next slide. Today's fast-paced world, traditional feeding practices oftentimes get overlooked. Breastfeeding particularly can be misunderstood amidst busy lifestyles, conflicting online advice, and societal expectations. The intricacies of breastfeeding, like from milk supply to latch, positioning, mastitis, cluster feeding, and weaning, they all present numerous challenges along the journey. And so prenatal and postnatal education classes have emerged as vital resources to navigate these complexities, especially during one's breastfeeding journey. They not only address lactation issues effectively, but also enhance patients' health outcomes and confidence. Group patient education focusing on breastfeeding is paramount as it not only boosts self-assurance, but also improves mental well-being and reduces the risks of diabetes, obesity, and other short and long-term illnesses for both mom and baby. For instance, research shows there's a 50% higher risk of type 2 diabetes among women who never exclusively breastfed compared to those who exclusively breastfed for at least 1 to 3 months. Next slide. In the Physician Services Handbook outlined in Utah Policy 8-11.6.3, Group Prenatal and Postnatal Education, Utah Medicaid reimburses for improving education on pregnancy, labor, childbirth, parenting, and infant care. The planned educational service aims to promote informed self-care, prevent the development of conditions that complicate pregnancy, and enhance early parenting and childcare skills. The comprehensive policy includes telehealth, group patient education, prenatal and postnatal coverage, all of which are commendable initiatives. However, the current reimbursement rate for the group prenatal and postnatal education classes, which is CPT code S9446, stands at $9.92, rendering the qualified providers unable to utilize or offer these crucial services due to the insufficient reimbursement. Even though Aeroflow offers 90-minute classes, providers receive the same reimbursement regardless of the session duration. And this issue is exacerbated by a max benefit of 8 visits per patient for a non-time-based code. This kind of results in a total reimbursement of group patient education that falls below $80 per member. Providers eligible under the Utah Policy 8-11.6.3 are those educated in patient education and certified in programs requiring a minimum of 120 credit hours, which is equivalent to 4 years of full-time study. Notably, half of the qualified providers possess master's degrees, exemplifying their expertise and dedication to quality care. These providers represent the caliber of professionals that one would entrust with the care of their loved ones. Next slide. We believe increasing reimbursement for CPT code S9446 is crucial. Proposing a $20 rate change would provide better compensation for qualified providers. So following the rate adjustment, each member would then receive $160 benefit for prenatal and postnatal education classes in total. So our aim is to match reimbursement rates with the national average for the respective code. But it's also important to note that Utah Medicaid doesn't have a designated code for lactation classes, whereas the National Lactation Consulting Code is reimbursed at approximately $86 per class. Increasing reimbursement rates has multiple advantages, from better access to care, attracting more providers, and expanding expertise, all benefiting patients with more resources. It leads to improved health outcomes by raising patient awareness and reducing the need for costly interventions. It also aids vulnerable populations by lowering the demand for unnecessary medical services through preventative health education. In summary, Arrowflow Health advocates for increased reimbursement rates to ensure equitable access to crucial support and resources for mothers and babies, particularly those most in need. I leave you with this question. Considering that Medicaid covers 21% of births in Utah, does an $80 reimbursement sufficiently capture the value of prenatal and postnatal education for the mothers and children of Utah who are most in need of the support? Thank you.
Thank you, Haley. We appreciate your presentation. Next, we have Tim Cox from the National PACE Association. Tim?
Thank you. I appreciate the opportunity today to visit about the PACE program. Quickly, let me go into what PACE is and how it works. PACE had its start in Chinatown in San Francisco in the early 70s, and they were struggling to provide care to grandma and grandpa while the parents went to work and the grandchildren went to school, and grandma and grandpa were home and nobody there to care for them. So San Francisco, they started a program. It was called Unlock to initiate a program where they transported the elderly to the PACE site and took care of them during the day, and then at night they went back home with the family. Centers were developed, and it was a great program. The federal government looked at it and said, that program has some merit, and so they did demonstration programs in the 80s and 90s. And at the beginning of the century, PACE was finally approved as a federal program for the elderly. PACE is a service that provides comprehensive medical and social services to the frail elderly participants still living in the community. And what that means is they can stay home. Most participants who are in PACE are dual eligible for both Medicare and Medicaid, and each enrollee must be nursing home eligible. So they have to qualify to be in a nursing home. The way PACE works is it uses an interdisciplinary team consisting of professional and paraprofessional staff that assesses an enrollee's needs, develop care plans, and delivers all services, including acute care services, and when necessary, nursing facility services. You can see from the handout, each one of the required services that is mandated as a part of the PACE program, the interdisciplinary team members. This team meets on a regular basis, sometimes talking about individual participants on a daily basis as care needs change. It's really a great model that takes care of the elderly, especially these that PACE serves that have chronic needs. Historically, long-term care services and supports have been provided primarily in the institutional settings like nursing homes. However, more recently, there's been a push and an increase for long-term care to be provided in homes in a community-based setting. PACE is trending in that direction, and most states are turning to PACE as an option for that delivery of care, as there's a high need supporting the ability to live at home and other non-institutional settings. PACE can also save states money. It's a federal requirement that the PACE programs are paid less than the amount the state would receive, would spend on a similar population. Therefore, the states work with an actuary to estimate how much the state would spend if a person wasn't enrolled in PACE, and then the states decide on a monthly per member amount that is less than the estimate. On the average, monthly capitation pays 12% less than the state would otherwise receive. Besides the potential savings to the Medicaid program, PACE has a high rate of satisfaction, both from the participants and their families. Participants rate the satisfaction as high as 4.1 out of 5, and the disenrollment rate is 5% less than in Medicaid Advantage programs. Moreover, 95% of the family caregivers would recommend a PACE to someone in a similar situation. We also see that PACE enrollees are less likely to suffer from depression. We see lower hospitalization rates, decreased rehospitalization rates, and a lot of improvement in the health as the program works to improve those settings. While all PACE participants meet nursing home level, PACE participants have a low risk of being admitted to a nursing home, with only about 4.5% of PACE participants residing in the nursing home. Closing, let me say that I was able to see firsthand. I established 4 programs in the state of North Dakota. And as I would go around the different programs that we ran, people would come up to me and say, "Thank you for this program. This saved my life." Our ask would be that the state consider implementing a PACE program so that a group of people can be benefited from this great program. And thank you very much.
Thank you, Tim. We appreciate your presentation on the PACE program. Next, we have James Whipple from the Utah Association of Community Services.
Hi, thank you for the opportunity to be on here with you today. I'm going to hand it over to Jim Jensen, who's our sitting president of UACS, to start us off.
Hello, my name is Jim Jensen. I'm the current president of the Utah Association of Community Services. We are a private provider trade organization that represents a little over 40 providers in the state. And with those providers, we provide the majority of the services to folks with disabilities through DSPD in community-based services. Next slide, please. One of the issues that we are constantly faced with is keeping people safe, healthy, and maintaining their eligibility. Although this is a relatively small part of what we do, it really integrates into our overall services and supports. Behavior supports that we provide help people to remain safe in the community, who may have problematic behavior. It teaches staff how to support those people when they're struggling. In terms of healthcare, we have nursing supports that support people to safely get their medication, to work with physicians to make sure that all the relevant and pertinent information is given to the physician to make good quality decisions regarding their healthcare. And then with regards to eligibility, we're also charged with supporting people to maintain all of their eligibility, whether that's Medicaid, Medicare, Social Security, housing, food stamps, all of those type of eligibility things. We are constantly supporting people to maintain those. Next slide. As we've talked as an organization, the one thing that we feel that is needed at this time is rate parity for our behaviorist nurses and the folks that provide the rep payee support. We've been working with the Department of Health and Human Services and DSPD, looking at our rate structure and other services and supports within Medicaid to create some kind of a parity. To accomplish this, we are hoping for the MAC support, as well as the governor and the legislature to appropriate the appropriate funding to maintain these critical services and supports in the system. James?
Yeah, next slide, please. So we've provided some data here. We'll let you peruse that at your leisure afterwards at some of the rates that are offered in similar service lines on other waivers and on the Medicaid state plan. You can go to the next slide as well. We provided that data for behavior support services, for nursing support services, and also for the personal budget assistance services. And we're not here just to ask you to address this parity just for the sake of fairness. I would really like to go a little bit deeper into the critical need behind these specific services. If you can go to the next slide, that would be great. So we're going to talk a little bit about some of the challenges in the field, but just to kind of illustrate the problem. So DSPD currently has over 5,000 people on the waiting list, and as far back as I can remember, certainly well over a decade, they've had thousands of people on the waiting list. And the methodology that is typically used to get people off the waiting list and into services is rating them by need. And so those with the highest level of need typically come off that waiver. So if you look back at the last decade plus of all the people that have come out into the community that have this highest level need, you're going to see a lot of people that have behavioral or medical needs that need help and need those needs to be addressed. Now, there's a lot of individuals that are being supported in homes and residential programs and day programs, but these people that are coming off the waiting list or that are already in our services can only be supported in these residential or day programs if they have this type of specific critical help with behavioral challenges or severe medical needs. These are both very critical services. I don't really need to go into, I'm sure all of you are very well aware of the nursing shortages that are crippling our country and our state. We certainly are feeling that in our industry. I can tell you from personal experience, it's taking us months to hire RNs and keeping them is an even bigger challenge. And behavior specialists, BCBAs, are also in high demand right now and are frequently leaving our industry to go externally where they can make at least $20,000 a year more than what they're getting with us. So we would just ask you to look at this critical need. These truly are the services that make the other services possible and that help us keep people in the community in these settings that are going to help them live their best self-determined lives. And we'll just leave it there.
Okay, thanks so much for your presentation. We appreciate the information. Next, we have Dr. Rampour from the University of Utah. Doctor?
Great. Thank you guys so much for your time this afternoon. My name is Shervin Rahimpour. I'm a neurosurgeon at the University of Utah. In particular, I am the director of the functional division here in epilepsy neurosurgery. It's a real pleasure to be here. Next slide, please. This is a topic that's near and dear to my heart as my cousin died from epilepsy, and this is a procedure that targets this very pathology. These are two CPT codes that are currently not covered by the Utah Medicaid insurance. And so my goal here today is to convince you that this is something that's desperately needed by our patient population. Next slide, please. So what I'll be talking about today is known as laser interstitial thermal therapy, or LIT. So we're going to go over technically kind of overview of that, what that is, some clinical evidence that really supports the use of this technology, its specific uses, in particular drug-resistant epilepsy, and then some summary slides over payer coverage and guidelines from our national societies. Next slide, please. So in brief, LIT is what it's commonly called, but also known as laser interstitial thermal therapy, is a procedure where a surgeon places a laser catheter inside of the brain. It's a minimally invasive procedure. Typically, a very small incision is made, and this laser catheter is placed with very high level of stereotactic precision, less than a millimeter of inaccuracy. And what we do is we ablate a diseased brain tissue. Because it's minimally invasive, patients typically spend less time in the hospital, typically 1 to 2 days. And it's really not a new or sort of unfounded procedure. Over 12,000 procedures have been done in the United States, which for neurosurgical procedures is a lot. And that's done across 200 different centers. Next slide, please. Great. So this is a system that's fully integrated with an MRI. So basically, a patient has this fiber placed in a very precise fashion in the area of diseased brain tissue. And using an MRI, we can visualize exactly the brain tissue that we are damaging. So we turn on the laser probe, and with the MRI, we get live feedback into what we're damaging and do so in a controlled fashion. Next slide, please. The principle is pretty basic and kind of intuitive. You turn on the laser, the surrounding tissue absorbs the heat, and as that temperature kind of gradually goes up, you end up damaging brain tissue irreversibly. So no different than if you went in and actually removed that area of the brain. This kind of damage also serves the same effect. Next slide, please. So I'm sorry, this video didn't come in, so we'll skip that slide. But let me give you one example, which is epilepsy. So the scope of the problem is that roughly 3 million people suffer from epilepsy in the United States, and roughly a third of them do not respond to medication. So those are patients that we have to consider for surgical options. So that's up to 1 million patients. Next slide, please. Currently, surgical options for them are typically very invasive, involving an open craniotomy. So here's a picture of what that incision might look like. And so a lot of these patients end up not wanting to undergo this. So throughout this, these less invasive options have become more developed, and laser ablation is one such option. It requires a small incision, and more importantly, a shorter medical burden on the system in terms of length of hospitalization and readmissions, which I'll show you in some other slides. Next slide, please. So there have been several analyses comparing both open surgery, as I just showed that picture, versus this minimally invasive approach known as LIT. Those outcomes are both effective in terms of how the seizure freedom rates, but also the complications that these patients experience. So in this table, you can see the surgical rates of complications with respect to hemorrhage or different deficits and infections the patient can have, and how LIT outperforms that. Next slide, please. This is a large prospective study that was done. So retrospective data is often a little bit difficult to interpret, but prospective studies across 10 centers in the United States have also corroborated this information. I've outlined a lot of this detail in appendices that I also submitted with my presentation, that I won't be, waste your time here with that. But in essence, if you go to the next slide, please. The seizure outcomes are comparable to open surgical resection, and again, with less burden on our healthcare system. Next slide, please. So in summary, we have a positive sort of outcome in terms of seizure efficacy. Most patients report an improvement in their quality of life, which is our goal. It's a less invasive procedure than an open craniotomy, and more importantly, it's also shorter hospitalizations with less pain medication requirements. Next slide, please. And meta-analyses, meaning more than just one study, corroborate this information when we summarize that evidence. Next slide, please. Beyond just the evidence I've shown you today, also patients have better cognitive outcomes because it's a less invasive procedure. Next slide, please. And the national trends corroborate this. People are undergoing less and less craniotomies and open craniotomies and undergoing laser interstitial therapy, as shown by this study. Next slide, please. We also see this as far as a national trend. Since the introduction of this technology, we've seen a gradual increase in the utilization of laser interstitial thermal therapy and a decrease in open craniotomy. Unfortunately, the burden of refractory epilepsy continues to increase on a yearly basis, and it's our goal as physicians to kind of cater to this. Next slide, please. The safety of this procedure is well established compared to open craniotomy literature across the board with respect to injuries, time spent in the hospital, as well as complications. Next slide, please. And again, I've summarized that here between the two. What I also want to highlight on this is the recovery time, as well as the 30-day readmission rate, which is also a significant portion of our medical expenditures, patients coming back to the hospital. Next slide, please. So payer coverage, our two big national societies, the AANS and the Congress of Neurological Surgeons, have supported this, and I've included those guideline statements in my presentation and materials. Next slide, please. And we are seeing that, across the country, there are a multitude of commercial payers as well that are allowing for LIT, as well as state Medicaid plans, 33 of which I've listed here. Unfortunately, Utah is not one of those states, and I really implore you that this is a patient population that is significantly suffering from refractory epilepsy. We, as physicians, really have a duty to offer them procedures that can be effective, that improves their quality of life, helps them become more meaningful contributors of our society, be able to get back to work, and so forth. And unfortunately, I can tell you stories upon stories anecdotally of my patients who unfortunately cannot undergo this procedure because they have the state Medicaid plan. So thank you very much for your time.
Okay, thank you, Doctor. Appreciate the presentation of the information. Next, we have Kevin Clark and Guido Vandenbos for therapeutic footwear. Please proceed.
Hi, thanks. Yeah, I'm Kevin Clark. I'm the president and owner of Priority Footwear, a family-owned business. We're based in Portland, Oregon. Next slide, please. We do one thing and one thing only, and that is diabetic footwear. Our mission as a company is to save diabetic feet. We saw about 12,600 people in Oregon, Washington, and Utah last year. We're contracted with Medicare, Medicaid, and almost all private insurers. Currently, Utah diabetics are underserved because of non-coverage by Utah Medicaid. And I'll make a case for that. Next slide, please. So diabetic foot problems. Approximately 11% of any given population in the United States is diabetic. This translates in Utah to about 300,000 Utahns with diabetes. The biggest problem that diabetics have with their feet, and most people are not even aware of this unless they have a diabetic in their family, are foot ulcers, which lead to amputations. Approximately 15% of diabetics develop foot ulcers. A large portion of those, up to a quarter of those foot ulcers, lead to limb amputations, usually starting with the feet and with the toes and working up the feet. And about 80% of toe and foot amputations by diabetics begin with foot ulcers. In 1993, the U.S. Congress passed a bill called the Therapeutic Shoe Bill, which mandated Medicare to provide proper footwear and inserts for people with diabetes with specific qualifying conditions. And this has been now in place for about 30 years and widely recognized as a significant life and cost-saving measure. Next slide, please. Medicare, as I said, covers it. Most Medicaid programs nationally cover it, and all private healthcare insurers cover therapeutic footwear and custom inserts annually. And what that includes is a pair of shoes which are Medicare certified, which provide the room necessary to deal with diabetic neuropathy and other issues. And also annually three sets of custom inserts for that diabetic's feet, and then toe fillers in the case of prior amputations to accommodate that. The total cost for the annual benefit for a standard set of diabetic shoes and inserts per patient currently, according to Medicare reimbursement rates, is just under $500 or $490.40. This, as I said, a cost and quality of life issue. The minimum economic cost for a single toe amputation, if you're just looking at the economics, is the stated rate is about $4,609 to have a toe amputated. So the provision of therapeutic shoes and inserts is generally seen as not only a cost-saving measure, but a very significant quality of life issue. Next slide, please. So our request as a company is really on behalf of all diabetic Utahns. We request that Utah Medicaid follow the lead of Medicare and other states to include an annual benefit for those particular billing codes which cover diabetic shoes and inserts, and who qualify under Medicare guidelines. We currently have a clinic in Bountiful, Utah, and are serving most of the population to the extent that we can down through Salt Lake City and in that entire western side of the state. So that's really about all that I have, and I would be happy to answer any questions if they come up as you're reviewing this. And I really thank you for your time and reviewing this.
Thank you, Kevin. We appreciate your presentation and keeping to the allotted time.
Yeah.
Next, let's proceed with Monica Frederick, please.
Thank you. Yes, thank you so much for the opportunity to present Free Spira. FreeSpira is FDA cleared for the treatment of post-traumatic stress disorder and panic disorder. We are here to respectfully request your approval of FreeSpira as a covered benefit for Utah Medicaid members. FreeSpira was founded with a tremendous amount of passion. There was a woman who was suffering with panic, and she enrolled in a study at Stanford University and was so thrilled with the study outcomes that she founded the company based on the Stanford Study Treatment Protocol. And that's what we deliver to patients in the home today. The Stanford researchers recognize that people with panic disorder and post-traumatic stress disorder tend to have dysfunctional breathing. They're chronic hyperventilators, they're yawning, they're sighing. This arises from a hypersensitivity to carbon dioxide. So they thought if we could normalize their breathing, could we eliminate or significantly reduce the symptoms of panic and PTSD? And yes, they can. One thing I want to mention is the symptoms for these conditions are primarily physical. So patient feels like their chest, their heart is going to pound out of their chest. They're nauseous, they're shaking, they're sweating, and they don't think, I'll call my therapist. They wind up at the emergency department, primary care, a lot of cardiology, gastroenterology. So the cost for these members is primarily driven by medical spend. Next slide, please. This is how we deliver the treatment to patients in their home. You can see the FreeSpira system on the left there. The patient receives the system in a small box, and there's just a simple nasal cannula that samples exhaled air. That is attached to a proprietary sensor. That's the item with the FreeSpira logo. The sensor measures exhaled carbon dioxide and respiration rate. That information is Bluetoothed to a small tablet that's part of the FreeSpira system. You see it on the slide there. And the ask for the patient is pretty simple. Breathe in sync with rising and falling audio tones and watch on the tablet your exhaled CO2 and respiration rate and work to bring them into the normal zone. Patient does this for 28 consecutive days, twice a day. And then they put the system back in a box, ship it to FreeSpira. They have learned a self-management skill that they can use in any triggering situation. Importantly, each patient is assigned a FreeSpira coach who stays with them via telephone and Zoom calls throughout the 28-day treatment. This really drives adherence. Next slide, please. This is one of 6 studies. I've set the studies for your review. And this study, all the studies had significant symptom reductions. This study, the researchers looked at total cost of care 12 months pre-FreeSpira treatment, total cost of care 12 months post-treatment. And you can see a dramatic reduction, 35% reduction in total cost of care, and then you can see 65% reduction in ED costs, and as well as 68% reduction in pharmacy costs. At this point, I'd like to hand it over to Dr. Malika Clausen.
Good afternoon. So I am a double board certified adult and child and adolescent psychiatrist, and I'm also a consultant for FreeSpira. My career has primarily been spent working with and advocating for Medicaid eligible and other traditionally underserved patient populations. So I'm here today to implore you to consider FreeSpira as a covered benefit for Utah Medicaid members. So the CDC estimates that about 1 in 5 adults will experience a mental health condition in their lifetime. However, less than 50% of those are able to access the treatment that they need. Part of this is due in part to a lack of access to mental health treatment. We know that about 40% of the country lives in areas that are considered underserved in terms of mental health professional shortage areas. We also know that 20% of the US population lives in areas that are considered rural areas. Additionally, we know that of most traditionally underserved populations, there are glaring disparities in access to quality healthcare in general, and we can assume that this also translates into difficulties with accessing mental health treatment and disparities in that area as well. Given that FreeSpira is an in-home treatment, it makes treatment readily accessible to patients no matter where they live. Treatment includes the coach, as Monica mentioned. That coach actually supports and trains and guides the patient and is an integral part of the free spirit treatment. I believe that improved access to innovative treatment like free spirit is critical to reducing the disparities that exist in terms of access to mental health care treatment today. Thank you for your consideration of free spirit as a covered benefit for Utah Medicaid members.
Thank you, Dr. Clausen and Monica. We appreciate your presentation. Next, we'll go to Julie Hadlock and Rebecca Dutson from the Children's Center.
Thank you so much. My name is Rebecca Dutson, and I'm the president and CEO of the Children's Center Utah. Next slide, please. Oh, we've got our old presentation, but that is okay. Our organization was established 60 years ago. We are the only organization in Utah providing evidence-based, trauma-informed mental health treatment to infants, toddlers, preschoolers, and their families and caregivers exclusively. Our mission, of course, is to provide for the well-being of children and families in Utah. If we could go to the next slide, please. According to the CDC, as many as 20% of children in the US will experience a mental health disorder. And in Utah, we are among a group of states with the highest prevalence of child and adolescent mental health disorders and the highest prevalence of youth with untreated mental health needs. In fact, in Utah, of our 468,000 children ages birth to 8, as many as 90,000 could experience mental, emotional, developmental, or behavioral challenges. Moreover, 58% of children ages 3 to 17 in Utah with a clinically diagnosed mental or behavioral health condition did not receive treatment. We all know that it costs less to invest early through promotion, prevention, and early intervention, and that resources are saved later in life when it is costlier to treat a crisis. Approximately $247 billion is spent each year in the United States on lost productivity, mental health and health services, and crime as a result of untreated mental health disorders in youth and children. Early stressors, including maltreatment, trauma, and poverty, are linked to a wide range of negative developmental outcomes, including poor emotional regulation and attachment difficulties. The work that we're providing, which is center-based clinical services, including family therapy, therapeutic preschool programs, psychological testing, and psychiatry services, ensure that we can go upstream to address the mental health crisis facing Utah's children and youth. And I'd like to turn the time over to Julie.
Thank you, Rebecca. Next slide, please. This is a completely wrong presentation. I'm sorry. I apologize. We'll make sure that we've got the corrected one. The presentation, the request that we have for this year is a few things. So when you're talking about services for young children, it's important to work with caregivers. And family therapy currently reimburses at a lower clinical rate than individual therapy, even though it's more complex to work with those families. So we're seeking at a minimum parity in rates between individual and family therapy. Additionally, we are aware of other states that are using a modifier to reimburse at a premium, those that are doing dyadic evidence-based treatment models, because that is the most effective. And so we'd like to look at a premium for those services. There's an interactive complexity code, which acknowledges the complexity of having to do things like engage family members in services, use translation services, use therapeutic toys and sessions. Currently, Medicaid has a $0 reimbursement rate on interactive complexity, and we'd like to request a reimbursement rate on that is average to private payers. And then our therapeutic preschool services, these are children that are receiving these services that are facing the the most significant mental health needs, often coming from trauma and adverse childhood experiences. And this is essentially intensive outpatient day treatment. The UN modifier is used for the intensiveness of it. And we're requesting an increased reimbursement rate from $7.49 a unit to $10 a unit, so that we can, again, sustain the work that we're doing for these most vulnerable populations. So again, this is the incorrect presentation. We'll make sure that we get over the correct one to Sharon so that you've got the information about the need and about the request. Thank you.
Okay, thank you, Julie and Rebecca. Next, we have Dave Clark and Bobby Jin from the Utah Assisted Living Association. Please proceed.
Hello. Yes, thank you for your time. My name is Dave Clark. I am a provider of assisted living in the state of Utah. I'm currently acting as a treasurer for the Utah Assisted Living Association. So assisted living provides basic foundational care for an aging senior population. We provide housing, meal services, social engagement, and then other services for activities of daily living, like medication management, bathing, dressing, and other critical needs. We don't provide intense medical services like that of skilled nursing, but we provide a more independent setting for people who are unable to live independently without 24-hour oversight. New Choices Waiver is the Medicaid waiver program that helps provide those services for people who are unable to pay for that privately or don't have the family support to live at home or family support that can help pay for those services. So really, that program really provides critical services for an aging population that is in need. So currently, the average cost for providing services in assisted living is about $120 to $125 a day for assisted living, or $140 to $145 a day for memory care. The current New Choices reimbursement rate is about $79. In the last 20 plus years, that program has received one increase. Currently, you couldn't even stay at a Motel 6 for $79 a day, let alone provide housekeeping and meal services, nursing oversight, and activities of daily living. So we're really in a critical time, and if we don't take some action, there's a high likelihood that this program will likely go by the wayside. Not because the program is being withdrawn, but because providers can no longer participate in the program. So if you can slide down to page 2, partway down, I want to show you even the next page a little bit. There's a COLA rate, which is the cost of living adjusted rates. So currently, the reimbursement rate in the state of Utah is $79. As of last year, that placed us at the second lowest reimbursement rate in the United States. So facilities really need your support. Facilities want to provide this service to those that need. We want to provide for people who are otherwise faced with homelessness, or the state is faced with putting them in a long-term facility such as skilled, which could be significantly higher. So in the last year, we've had 39 facilities in the state closed down. A large majority of those were providers of New Choices waivers, and they just could not keep up with the hyperinflationary costs. When you are seeing, the cost of nurses and the cost of CNAs skyrocket and everyone's competing for those, it's hard to keep up with that, let alone rising housing costs, insurance costs, food costs, etc. In the last year, the state of Utah hired Myers and Stauffer to do a third-party assessment, and they recommended on that the reimbursement rate really should be somewhere between $120 and $140 a day, and that was in 2022. So, we are really needing your help in order to make this viable for our seniors. I'm going to take that's the time I want to take. I'm going to pass it over to Bobby Ginn to share a little bit more.
Yeah, real quickly, my name is Bobby Ginn, and I'm also a member of the Utah Assisted Living Association Board of Directors. The silver tsunami is here, and it's only going to get larger. Baby boomers will be an even larger portion of the Utah population over the next dozen or so years than it is right now. The Medicaid New Choices waiver program is currently fading out and not being used because assisted living communities are losing money when they accept the New Choices waiver residents, because the reimbursement rates are so outdated. If there are no assisted living communities for the seniors in Utah to live in, they'll most likely go to the streets and be homeless or live in expensive long-term skilled nursing homes, and that are costing 3 to 8, maybe 20 times more than assisted livings. We need to dig in deep and find a way or ways to support our lower income residents and upgrade our Medicaid New Choices waiver program to catch up with the cost of living in Utah. If we don't take big action this year and ongoing each year after that, our baby boomer silver tsunami is going to impact our state in a negative way. We are asking the MCAC committee to support this request and help us urge the governor to recognize how important our seniors are to our state and support up-to-date and fair reimbursement rates. That's all I have. Bryce, do you have a second or two of thoughts?
Yeah, real quick. My wife, Emily, and I own Oasis Senior Advisors. We're like a real estate agent for clients to find assisted living communities. And I have no monetary gain in being on this call, but what I see every day breaks my heart. In speaking on behalf of seniors, we see the potential for our clients going to an assisted living diminishing year after year after year, simply because these communities that still do have and honor the New Choice waiver, these communities are reducing the potential for these clients to move in, and also the conditions that the communities that still do honor the New Choice waiver. I'll just be honest with you. We have clients cry when we take them into these communities and say, this is where you have to live out the rest of your years. I am telling you, we're not in trouble mode. We are in crisis mode. We strongly encourage you to consider increasing the rates of the New Choice waiver. Thank you.
Okay, thank you. Appreciate the three of you and your presentation. Next, we have Tom Forty from Innovus on bone growth stimulators.
Hi, this is Willie Kaplan. Tom and I are presenting together. We are with the bone growth stimulators with DJO. We're asking for reimbursement rate for the E0747, E0748 for bone stimulators for Medicaid in Utah. Thanks for having us. Next slide, please. Bone growth stimulators have been around for a really long time. They are a class 3 device that there's a spinal application as well as a long bone application. They are covered in all the neighboring states around Utah for Medicaid and 45 out of the 51 states in the union. For spinal fusion, they're used as an adjunct treatment to spinal fusion to help to avoid repeat fusions or other procedures. And on long bone fractures, they are used with people that are 90 days out, or what we call a non-union, for people that haven't healed from their fractures in order to heal those fracture areas. The device we have is 30 minutes once a day with DJO. These are some pictures of what that looks like for those units. Next slide, please. What bone stimulators do, as we were said, they help to fill in that area with bone. Back in the 1800s, Wolff's Law came out. They said when you break a bone, that your body sends an electrical current across that area. It then tells your body to treat that fracture and fill in the area with bone. Bone stimulators do that in reverse. They trick your body into doing so with that electromagnetic wave, right, to recruit osteoblast cells, recruit osteoclast cells, lay down new healthy bones. Okay, these things have been around for a very long time. They have significant clinical data behind them. Some of the most recent data is from Johns Hopkins with significant proven on the spinal side of things for fusion rates, right? They also have a 21% increase from the FDA data that has been published with 5 and 10-year follow-ups for patients using the device versus not using these devices. There's a recent study on spine that shows these patients heal at 2.6 months faster when using a bone stimulator versus not. So for the patient population that we're talking about, helping people get them back to work, to their lives, to those things faster once they've had these spinal fusions, not having to have repeat fusions or other modalities. On the bone fracture side, it's the same idea, right? These help to reduce the non-unions or people that haven't healed in about 90 days or so. Those are at 35% in a level 1 metadata that was recently published. The FDA data are people that are at 75% heal rates for all the bones for people that are over 2 years out with at least 2.5 surgical interventions that heal with these devices. Next slide, please. Not only are these devices, they're obviously have the clinical aspirations of these devices, but they have the economic considerations. We're asking funding from you today, obviously for these devices, for your patient populations, but the costs associated with them are more than offset with the savings that you get in using the devices for these patients not having to receive additional modalities, surgeries, etc. Spine fusion is the most costly procedure in the United States. It's about $14 billion of these procedures. Readmits is also an extreme amount of costs for people. When you look at these costs for the patients and they stratify here, as well as some of the other data that we provided, you know, spinal fusion non-unions or pseudoarthrosis can be up to 35%. Bone stimulators help to reduce these fusion non-unions or pseudoarthrosis. And we know that obviously readmits are also an important piece. We don't want those as well. For the Utah population, as you can see here for Medicaid, these patients are at higher risk of having to go back in and costing on average about $13,000 a day. We're trying to avoid those costs by using a bone stimulator for these spinal fusion patients. When you're looking on a non-union side of things for bone fracture, same thing applies, right? Having fixation for these fractures is extremely expensive. Having to go back in and redo those fixation costs is also extremely expensive. There's a 2012 study from Medicare Metadata that has over 60,000 Medicare patients in it. They looked at using a bone stimulator versus not using a bone growth stimulator, and including the cost of the bone stimulator, it is cheaper to the healthcare system by over $2,000 to use the bone stimulator versus not using it. So in conclusion, we know these bone growth stimulators are proven. They've been around for over 30 years. They have both clinical and economic benefits that we are hoping to help heal these patients, not have to reoperate, have non-unions or pseudoarthrosis. All of these things are healthcare costs that currently there's not another option for these patients if we can't use these devices. We respectfully request your consideration for reimbursement for this technology for the Utah Medicaid patient population. Thanks for having us.
Thank you for your presentation. Next, let's move to Dr. Meltzer on prenatal testing.
Yes, thank you for the opportunity. My name is Jeffrey Meltzer. I'm a board certified OBGYN physician, and I've delivered over 3,000 babies in my career. I am representing Natera today, but I'd like to also say that other labs, including Utah-based Myriad, provide prenatal cell-free screening for pregnant patients. I'd like to review cell-free DNA screening, and in the US, there's a crisis of increasing maternal morbidity and mortality, and now more than ever, it's important that we have evidence-based quality care for patients, and that includes prenatal cell-free DNA screening. Over the past several years, 4 major laboratories have left the space of reproductive health testing because of unpredictable coverage or because of burdensome prior authorization requirements. Next slide, please. So cell-free DNA screening is a simple blood test done as early as 9 to 10 weeks that helps to detect the risk of a person having a baby with trisomy 21, 18, or 13. This is not new, but cell-free DNA screening is significantly better than serum screening. It provides better detection, fewer false positives, which result in fewer invasive procedures, and less procedure-related losses. Next slide. And before cell-free DNA screening, patients had no idea that they were at risk for having a baby with Down syndrome. And what we've seen over time is since cell-free DNA screening has been introduced, there's a massive reduction in the amount of diagnostic testing or amniocentesis. And without cell-free DNA screening, babies are often born in rural places and then transported to primary care facilities or in major cities. And by that time, there's increased risk for the child. Next slide. So what is the current standard of care in the United States? The American College of OBGYN says clearly that all pregnant people should be offered cell-free DNA screening. It's the most sensitive, most accurate, and predictable test for detecting aneuploidies. Next slide. The American College of Medical Genetics, not only that, they say NIPT or cell-free DNA screening should be chosen over any other available modalities. NIPT should be used primarily. Next slide. And Utah is lagging behind. The standard of care in the United States is cell-free DNA screening for all pregnant patients. 48 state Medicaid programs cover cell-free DNA screening. Utah is far behind. Almost every single commercial carrier in the United States covers NIPT. Next slide. We have a list of many providers in the state of Utah. Almost 100% of OBGYN providers prefer NIPT. Next slide. It provides health economic benefits. Not only is it better for the patient and their families, it allows them to prepare mentally, socially, financially for a child with needs. Next slide. We know that based on models, there is a limited increase in cost to the state of Utah. We've estimated using published models an increased cost of approximately $270,000 for the state of Utah. Next slide. So I'd like to introduce, sorry about that, I'd like to introduce Amber Mathiasen Phillips, who is a genetic counselor in Utah, who would like to give you some perspective from her practice.
Hi, everyone. Thank you for having me. So I think that if anyone can think back to a time that they were pregnant or someone they knew were pregnant, you could agree that this is one of the most significant times in a person's life, a time filled with hopes for the future and at the same time fears and anxieties. For a high-risk pregnancy, these fears are multiplied and may include needing to prepare for surgeries, getting set up with early intervention, or even preparing for the baby's death. To deal with these anxieties, patients want to be prepared. One consistent message I hear from Utah patients is that they hope to have a healthy baby, of course. And if not, they want to be prepared to make sure the baby does the best it can. Utah patients seem to prefer screening testing methods, as other options such as amniocentesis pose a small risk to the pregnancy. Cell-free DNA, as mentioned earlier, is currently the most sensitive and specific screening, and therefore we offer it to all patients. Utah patients seem to prefer this as it feels safe and accurate. Now, accuracy is important. I can remember a patient of mine who had a low-risk maternal serum screen, and her baby was born with trisomy 18 and died shortly after birth. Now, really, what a devastating experience to come home without your baby after thinking everything was fine. While having known this diagnosis during pregnancy may not have changed that outcome, patients benefit from preparing emotionally for that possible future. Now, contrast this with an experience of another of our patients who had a high-risk cell-free DNA screening for trisomy 13. This patient was, while pregnant, able to see Angel Watch, a perinatal palliative care program that helps parents prepare for this difficult transition. So while this is still a devastating experience, many patients value having this information while pregnant to prepare for that future. So overall, although these stories are short, I hope it illustrates the importance of preparation, accuracy, and safety to Utah patients. I hope Medicaid will consider what I've shared today and support patients by covering cell-free DNA screening.
Thank you so much, Amber, and thanks to the state of Utah. We appreciate your support.
Thank you for your presentation. Next, we have Mircea Devrisian for Camp Tag.
Thank you so much for having me, and it's so good to see you again and be back. I was here with you guys last year. So I think we can go to the next slide. We have a video. It's just 90 seconds. Let's watch this quickly, and then we'll chat right after that.
Sorry, you will have to give me a moment. I wasn't aware that you wanted the video played. Apologies.
All right, no problem. Thank you.
Okay, tell me if you can hear this.
What would you have done differently? Sure, a fire extinguisher does come in handy, except it would leave behind a huge mess to clean up. That is
on the ad.
all the steps to use one in the middle of all the chaos. Plus, 83% of Americans don't even use. But what do you
on the ad?
That there are better, cleaner, and faster ways to handle a fire.
That's just an ad. There's a button right there. If you push skip to the right of the screen on the bottom. Just on the bottom on the main screen, this is an ad is going to go forever. Right there. Perfect. Thank you. Yeah, if you can unmute.
Yeah, we're still not able to hear it, Sharon.
Sharon, are you there?
I just sent her an instant message to let her know.
Or a subtitle, we'll make work. It's good enough. I don't think we need to waste any more time. It was just a picture's worth 1,000 words, and a video hopefully is worth a whole lot more than that. So I'll just jump right into talking about Camp K. You saw that up there. I really would love to invite you all to come to Camp K. We are unique in the state of Utah. We are currently the only provider of services to DSPD regarding recreational therapeutic, clinical recreational therapeutic services for people with complex medical needs and disabilities. Last year, we have been selected to work with the state of Utah as there is a lack of access to respite services from across the state, especially in rural areas, for individuals to partake in respite services. And we will provide the services from across the state and provide transportation to individuals from St. George to Ogden to Camp K for a week of service. Currently, as you've seen in the video, we work with recreational licensed and accredited recreational therapists, and all our services are evidence-based, and we work on all 5 domains of functioning, from physical to cognitive to behavioral, social, and emotional functioning to try to improve the well-being of our individuals. We are
push play.
No, I think we're good with the video. We're past that. So our services that we would require support and an increase in our rate, we're paid at about $10 an hour. We provide full service supervision, one-on-one, one-on-two, whatever is needed. We got registered nurses on campus. We have recreational therapists. We have facilitators, lifeguards, cooks. We provide the meals here and housing for 1 week at a time. We get paid $10 an hour. Obviously, $10 an hour, you can't get a babysitter anymore. What about someone with a complex medical need that DSPD recommends and refers to Camp K? And our cost is very low. It's $25 an hour. We would really appreciate the rate to be increased, or the cost. We are a nonprofit, and donations have been very, very difficult post-pandemic for us to secure, to be able to subsidize the difference for the state for our services. And I do fear that if something is not being done, Camp K will shut down, and the one provider services that is the sole provider service for the state of Utah for the SPD will no longer be there available. So I really appreciate this opportunity. I invite you all up at Camp K. We are unique, not just in the state of Utah, but in many other states. Camp K is fun for our participants, but beneath that fun, there is a lot that goes into to help them become as independent as they possibly can. The respite care is very needed for those that care for them. However, our services have an impact on the whole community, and we would appreciate you helping us sustain Camp K for the future for our state and those that require our services. Thank you so much.
Thank you for your presentation, and sorry about the technical difficulties on the video. Next, we have Bo Sorensen on home health rates.
Hi, thank you for having me here today. I appreciate the opportunity. My name is Bo Sorensen. I'm with First Choice Home Health and Hospice, and I have been in the home health and hospice industry here in Utah for the past 24 years. And I'm here today to chat with you a bit about how we need a rate increase for our Medicaid home health rates. Right now, we haven't seen a rate increase for the past 6 years. I know that there have been some others on the call that have gone longer. However, with the rapid increases that we've seen in nursing, therapy, and aid costs, it's quickly becoming uneconomical for us to actually see patients on the Medicaid waiver, or excuse me, not the waiver programs, that's coming up later, but just on traditional Medicaid. And this is exacerbated even further with some of the managed Medicaid programs that actually pay less than the state rates, but that peg it to the state rates. So right now, we are seeing over the past 4 years, we saw a 25% increase in our nursing costs, a 56% increase in our aid costs, and therapy visits now are actually dramatically underwater, even at the base rate that Medicaid pays. So we actually pay our therapists about $20 per visit more than what we get from Medicaid currently for occupational, physical, and speech therapy services. So it is in a scenario right now where we as an agency are choosing to serve the community, and by doing so are knowingly taking a loss. And we think that this right here, especially coupled with the really reasonable costs that home health care services are for the Medicaid program and how they do help Medicaid, that it is appropriate to ask for an increase at this time. Right now, a recent AARP studies showed that 77% of folks want to age in place. They don't want to have to go into some kind of institutional care, and 70% prefer to have that care done at their home. That might be in an assisted living facility. It could be at their actual home or in an independent living. We can serve folks in all of those locations. And our care is 42% lower than care that you would get at a facility. And if we're able to keep people out of the hospital just one day in a year, that can often pay for up to 10 months of home health services on the Medicaid program based on the number of visits that we do. So it is extraordinarily cost effective and very beneficial for the state to do this. Right now, our nursing costs are covered only about 82% with current Utah rates, and so that's another one that is significantly challenging for us. Aid services only cover about 89% of the median cost for care, and so we are looking right now. There's nobody leaving the program, but I do see that in the next few years, if we don't get an increase, we will start to see the program dwindle, and with that, the cost savings that we can provide for the state. And one of the nice things about this is that our funds are matched by the federal government. And so right now we're requesting about $1.9 million. That's been matched by the federal government to the tune of $3.5 million additional dollars. So it's cost effective for Utah taxpayers as well to be able to get a lot of bang for their buck. So we expect that if this is funded, we'll be able to actually support the agencies and support the patients that these agencies are seeing for the next 4 years, or at least 3 years through this increase. So we really appreciate the time, and thank you so much for the opportunity to present.
Thank you both. Next, we have Catherine Morrison and Matt Hansen.
Thank you, Chairman Hales. Can you hear me okay?
Yes, we can. Go ahead.
Excellent. And I apologize for not being on video. I just flew into town, had a pre-booked flight that I wasn't able to arrange after the schedule got changed. But I am, more than anything, I'm going to introduce Catherine or Kate Morrison and Braxton Nurden, who are on our Government Outreach Committee. I'm the Executive Director of the Home Care and Hospice Association in Utah. And we have another request today, which is for private duty nursing. We have heard a lot about, and you'll probably remember from last year, the committee will, the request that we had for the HCBS waivers, which is something else that you will hear today. Private duty nursing is not far behind it as far as being in a crisis. Utah reimburses at a rate that is the second lowest in the area, less than $60. And we have, in some cases, there are some states that are almost reimbursing $50 more. So Kate's going to go over that a little bit with you, but I at least wanted to introduce myself and thank you for your time. Kate.
Thank you so much, Matt, and thank you everyone for your time today. A quick overview of private duty nursing. PDN is continuous skilled nursing care provided in the home for individuals, a lot of sick kids with medically complex conditions. Many of these patients require technology such as feeding tubes or trachs or vents to sustain life. The care is provided by RNs and LPNs in the home, and this is an alternative to being a hospital setting. Next slide, please. Thank you. So you've heard a lot of things today. I only want to leave you with 3 things right now. We sent out a lot of materials. First of all, due to low reimbursement rates, we have kids in hospitals throughout Utah that cannot go home because of those low rates. Rates make it capable for us to hire experienced nurses to bring kids home. So we have kids who are not getting sufficient care and kids who are just celebrating birthdays in hospitals because of low reimbursement rates. Next slide. And PDN care saves money. I mean, it's pretty obvious that care at home is cheaper than in a hospital setting. And if you look at this blue bar here, these are Utah-specific numbers, that it's about $2,000 a day to be in a hospital as compared to a little over 400 or 5 times more to be in a hospital. When you don't have significant care at home, it also leads, discharge delays, increased readmissions, just generally less stability for those kids with complex conditions. Next slide, please. Nearby states are investing in PDN. Matt referenced this. We have the 2nd lowest rates in the West, and other states have recognized the importance of increasing rates in order to get kids out of the hospital and home. These are some of the recent increases. See, Washington State has increased twice, actually, for pediatrics over the last couple of years, over 30%. So other states are realizing it makes good money. It makes good sense. It saves money, and it's morally the right thing to do. So one slide and then one more slide, and then I'll pass it on to Braxton. So our rate increases here. We know that the rates make a difference in utilization. We expect that with higher Medicaid reimbursement rates, we'll be able to hire more nurses and get kids out of the hospital. And this rate increase is on par with the last one we received in 2019. So I'm gonna let Braxton wrap it up for us.
Hello, my name is Braxton. I work for Maxim Healthcare. It's a local home care agency here based in Salt Lake City. I just wanted to share a story that highlights the need for increased rates. We have a current patient that has a trach and an vent who requires 24-hour continuous care. He lives in West Jordan, Utah, so you would think there are plenty of RNs and LPNs that live in that area because it's a highly populated area. The only care that he has outside of nursing care is from his single mother. She is also the only person in their household that brings in income. There's no other financial support that they have in the home. With his care, recently we found out that it's been very difficult to find a nurse that will stay there long term. A lot of that has to do with the rates. With the current rates that we have in the state, we can't compete with hospitals, long-term care facilities, and other facilities that are also competing to hire these RNs and LPNs with higher reimbursement rates, which usually means that they can pay those nurses a little bit higher of a wage. Unfortunately, what this has turned into is it has left this patient and his mom without several days a week of care that they could have nursing care if we were able to get a consistent nurse into the home. The result of that is that she's been missing work, which unfortunately has put her in a tough situation where a lot of times it's hard for them to pay their mortgage. It's hard for her to pay her utility bills. And honestly, the mom can't care for him 24/7 with that continuous care that he's needing. Our hope with these higher reimbursement rates for PDN care is that we'll be able to hire more consistent and long-term care for this patient and other patients that are in a similar position. So are there any questions?
That's great. Thank you. We'll not be taking questions today because of our time limits, and we'll have people reach out to you if they do have any. But thank you for your presentation on private duty nursing. Next, we have Dave Park from Home Instead on HCBS waiver rates.
So I appreciate the opportunity to be here. I know it seems like we come here every year, and we've always appreciated the support from this organization. But I'm here representing the HCBS Aging and New Choices waiver programs and in-home, and the fact that our rates have really hit a beyond critical point. HCBS reimbursement rates continue to be considerably lower than the market rates, putting the viability of the aging waiver and the new choice waiver programs in very critical condition. Last year, the MCAC committee, you folks, recommended an increase to these waivers, and we were ranked number 2 in the priority last year in the budget meeting, which was amazing. Full funding was also included in Governor Cox's 2024 proposed budget, ranked very, very highly for the Health and Human Services appropriations. When it went to the Health and Human Service Appropriations Subcommittee, we were also ranked high. So we were feeling really excited that maybe we would be able to save these programs. However, the petition was completely ignored at the Executive Appropriation Committee, and no funding was approved, none whatsoever. The damage to that, the outcome of that has already happened. Of course, you're not going to remember our presentation from last year, but we talked about how we went from having 72 providers in 2022 to 50 in 2023. Right now in 2024, we have 34. So providers are dropping out of these programs because it is just, we've always lost money, but now the losses are so big that companies can't even stay in business. And a quick reminder, these waiver programs, the aging and the adult and the new choice waiver programs, both programs are where a medical doctor has said these people cannot safely, under medical conditions, live without some support. With New Choices waiver, the individuals have to be in a facility for 99 days. And then if the doctor says, well, they could go home if some help follows them. And that's what we're requesting. And that's where we're so concerned about the fact that these rates are so low. I'm one of those 34 vendors. There are only 4 providers, only 4 providers that are currently supporting the aging waiver program here in the state. 4 that are left. I'm one of those 4, and I only have 1 client left. I've had to release the other ones, and I'll tell you what, you talk about gut wrenching. This was probably the biggest moral dilemma that I've dealt with as a business owner, but we had to release people or I was going to lose the business. So I have 1 aging waiver client left, and I'm one of the 4. So you can imagine how destitute this industry is right now. A quick look at the costs, and I think you can maybe, if on the next slide, I think we have maybe some more, or maybe this is the only slide we set up. That's okay. The average cost for having someone use New Choices waiver and stay home is $1,600 to have them be at home. If they do have to go into an assisted living and they're using New Choice waiver numbers or New Choice waiver funds, the cost increases to just under $2,600. So it goes up quite a bit. If they end up in a skilled nursing facility, it goes up to over $5,000. It's $5,462. And this is information that we glean from the DHHS studies. We're asking for funding right now. If we don't, there are 2 places these people will be. One is they will be homeless. Or 2, they will be in nursing homes, and Medicaid will be paying top dollar for them to be in skilled nursing facilities. This is not a good use of our funds, and we really do ask for you to consider this. Please help us to be able to save these people in this program. I'm actually here in the home of a friend of mine who is one of our clients. Her name is Kathy Garber, and she participates in the New Choice waiver program. I asked her just to share a little bit.
Good evening, and I appreciate this opportunity to share my testimonial of home and community-based services. I am a certified social worker, and for the last 1.5 years, I've been working with addiction and recovery services here in Utah. And I want to say that without the assistance of the new choice waiver and individual agencies like Dave's agency, Home Instead, I would in fact be put back in a nursing home and not being able to contribute to society, to my community, and those that other individuals with disabilities that I advocate for. And I ask that you consider increasing the funding for home and community-based services and Home Instead and the agencies that are represented here. And I really appreciate your time and attention, and I don't envy your decision whatsoever.
Thank you, Kathy, and thank you, Dave. We appreciate your presentation. That's very helpful.
You're welcome. Thank you for your consideration. Appreciate your support.
Okay, let's move to Jeff Trainer and Senator Judson Hill.
Hey, good evening. This is Judson Hill. I'm going to go first, and then I'll pivot over to Jeff, and I greatly appreciate y'all's time today. Rather than requesting funds, we're grateful for the time here to share more about my medics and as well as how Utah Medicaid can save money and prevent many expensive leg amputations. So how would we do that? Increasing patient access to skin substitutes improves healthcare and saves money. Delayed access is often very expensive, and that'll be my focus here. So we aren't here requesting money nor state appropriations. Today, Utah Medicaid only reimburses for skin substitutes for advanced wound care in the hospital setting, not in the doctor's office. Skin substitutes, as you may know, are specialized wound care products used to heal the very worst wounds in chronic skin ulcers. These are those wounds that don't heal with standard care techniques. Today, patients with chronic wounds that have not healed with standard care are then referred to the hospital for treatment. In the hospital, though, they often wait 3 to 4 weeks to be treated. This is a very critical time for the patient, and a 3 to 4 week delay or a gap in treatment often makes the difference between saving the foot or lower leg or requiring an amputation paid by Medicaid. And this is often what's happening here today in Utah. Simply, delayed access in this gap in care is expensive. Here's the very rough math of how money can be saved by adding the physician office reimbursement, for skin substitutes. National statistics show that a lower leg amputation direct cost can easily exceed $100,000 when you calculate the hospital, drug, rehabilitation costs, long-term medication, and also if you add in other indirect costs such as disability care and social services by the state. Currently today, Utah is incurring many of these costs for numerous amputations. But conversely, seamless access to skin substitutes for a typical 12-week episode of care in the physician office may run $12,000 to $15,000 often with a 75 or so %, maybe higher healing rate, and of course avoiding the amputation. And that's a very significant savings over the cost of an amputation for not treating these patients seamlessly in the physician office. So what this means is the state saves money when the patient has continued access to skin substitutes without a delay or gap in care. It's a much higher rate of return, and the math really makes sense. Better access saves money when Utah Medicaid reimburses for skin substitutes in the doctor's office for medically appropriate patients. I want to thank you very much. I know we're speaking fast through these, and I'd like to turn to Jeff Trainer, who's with MiMedx, a colleague, and can share more, and we'll talk through perhaps some of the slides. Thank you.
Next slide, please. Yes, and thanks for your time today. So what are skin substitutes? Well, they're an important option available in preventing amputations, and they're utilized typically at the 4-week mark after conservative treatments have failed. These are products that are currently covered by Utah Medicaid, but only at the hospital outpatient setting. And these are standard of care now. So we're looking for coverage at a site of service 11, so the provider office setting, and that's currently covered by Medicaid, covered by the majority of state Medicaids, covered by all national commercial payers, as well as the majority of regional payers. And the rates are already established by the CMS Part B fee schedule. Next slide, please. So why does improving access to care matter for these lower extremity diabetic ulcers? The vast majority of patients who have this type of ulcer will heal with standard care, and no other additional treatments will be required. However, if an ulcer does not heal within 4 weeks or that 30-day time period, it's considered chronic and may require an additional treatment or a skin substitute. So if they don't receive this, it'll increase if the diabetic ulcer has a duration of greater than 30 days, it's almost 5 times more likely to be infected and lead to high rates of hospitalization as well as lower extremity amputations. Next slide, please. I'm moving forward for time. This is how a typical Medicaid patient looks right now. They present at the treating provider's office. Provider institutes standard or conservative care. At this point, the vast majority of these cases will heal on their own. However, when the wound stalls at that 30-day mark, this is where you can see a difference of care and access disparity for the Utah Medicaid patients. If they were to have Medicare or commercial insurance or another state Medicaid, that treating provider at the provider office setting would be able to continue care right there. However, right now, for Utah Medicaid patients, the provider does not have that ability and must refer that patient at the HOPD. And as Senator Hill said, there can be up to a 3-week delay in some of the more populated areas or at busy times of year. Next slide, please. So what we're asking for is expanded access. And we believe that with this expanded access for treatment at the provider office setting, we can lessen the likelihood of amputations and costly hospitalizations. As mentioned, Utah Medicaid used to cover these products in this setting, but stopped. We're recommending that we add just common sense guidelines. We have examples from other state Medicaids, from Medicare, and as well as from commercial insurance, as well as covering a short list of products that have level 1 clinical data, which includes RCTs or randomized controlled trials, and finally using the CMS published reimbursement for the skin substitutes. And thank you for your time today.
I'm about to be
presentation. Okay, Andrew, let's move on to you from the Disability Law Center.
Good afternoon, committee. I'm Andrew Riggle, the Disability Law Center's public policy advocate. Sadly, much of what I'll say should sound familiar. About 82,000 adults and 34,000 children in Utah experience serious mental illness or emotional disturbance. Less than half receive treatment. As a first step, we endorse the Utah Peer Network's request of $1.26 million for a reimbursement rate increase for certified peer support specialist wage equivalent to $24 an hour, which you'll hear shortly. Please prioritize $500,000 for each of 4 additional local mental health authorities that expressed interest in assertive community treatment teams in response to HB 248 from 2023. ACT reduces crisis hospitalization and incarceration by providing intensive clinical, employment, housing, and other wraparound supports to individuals with SMI. There are also variations specifically designed for those who are unhoused or involved in the criminal legal system. In a 2016 brief, often notes a 2/3 decrease in inpatient cost and a 60% decrease in overall healthcare costs for participants. Because of a federal match, a team becomes self-supporting at around 75% capacity. Ultimately, we must develop a system focused on delivering the right supports at the right time in the right place. To this end, we strongly urge support of $500,000 for a study, as proposed in this year's HB 139, of the needs and gaps in the community mental health system faced by those with SMI. Our hope is it will also generate some of the data needed by the Behavioral Health Commission to oversee the implementation of the master plan. On the division of services for people with disabilities side, individuals leaving an intermediate care facility for individuals with intellectual disabilities with conditions requiring a higher level of medical care can continue to receive nursing services. However, those needing a similar level of care already in the community supports waiver or about to age out of the tech dependent waiver at 21 aren't so lucky. Therefore, we'd appreciate the MAC prioritizing this $4 million request highly once again. Conversely, young adults on the TDW can't access the DSPD services needed to be fully participating members of their communities. If 100 of the 145 individuals on the TDW took advantage of these supports for 8 hours a day, 3 days a week, the state cost could be around to just over $2.6 million annually. Over the last decade, only about 1,000 people have gotten off the waiting list, likely because individuals' needs become more complex as they wait and the dollars don't go as far. This is why we supported the governor's request of 1.6, just about $1.1 million for the limited support waiver, and to bring those who've been waiting 15 to 20 years into services. Likewise, we support a $1.225 million request in state money for this year's HB 324. Its pilot could delay the need for more intensive supports by offering Medicaid state plan services earlier to 124 families on and off the waiting list. Finally, Utahns using non-DSPD providers or self-directed services continue having trouble recruiting and retaining qualified direct care staff. In addition to a competitive wage, we'd appreciate the committee's support of $136,700 for HB 137 from this year, which would allow 100 working, aged, blind, or disabled enrollees to have up to 500% of the FPL in income and still receive the support needed to be as independent as possible. Thank you for your time and support of our priorities. Please feel free to reach out if you have questions or if we can provide more information.
Thanks so much, Andrew. We appreciate that. Next, let's go to Marissa Perales.
Hi, my name is Megan Gelker, and I'll hand off to Marissa. I'm the clinical strategy lead at ENT for Smith & Nephew, and we thank you for this opportunity. Our ask is for the Utah Medicaid program to expand access for tympanostomy procedures performed in the office setting with the TULA system. If you can go to the next slide. Perfect. The procedure is billed with CPT code 0583T. Each year, approximately 700,000 tympanostomies are performed on children in an operating room, making it the most common childhood surgery performed with general anesthesia. The TULA system, which received FDA approval and was designated as a breakthrough device in 2019, enables tympanostomy tube placement in an ENT's clinic without the use of general anesthesia, changing the site of service from the OR to the office. During a TULA procedure, the child's eardrums are first numbed using specially designed earplugs and a numbing drug solution. Then the automated tube delivery device is used to quickly and safely create the laryngotomy and insert the ear tube. 5 recent publications support the safety, effectiveness, and tolerability of the TULA system. And to summarize the clinical evidence, the TULA system showed positive outcomes with rates similar to those reported in the literature for conventional tympanostomy tubes placed in the OR, and there were 0 serious device, drug, or procedure-related adverse events. Marissa?
Thank you, Megan. So today, my name is Marissa Perales. I'm the Market Access Director for Smith & Nephew's ENT division. Today, I want to highlight the benefits of extending access to the TULA system for the Medicaid population. And I also want to talk a little bit about the health economics that can lead to decreasing the cost and offering a valuable option for patients. And then I will hand it off to 2 physicians. So while pediatric tympanostomies are commonly performed in the OR and are seen as a standard of care, the National ENT Society has issued a position statement in favor of ear tubes. For many patients and families, ear tubes are a procedure that means a loss of work or parents are missing a day of school. For the TULA procedure, the benefits of shifting the site of service to the office with the TULA system allows for the opportunity to lower the healthcare system costs, removing the facility and anesthesiologist fees. In addition, it has the ability to alleviate the resource time from facilities and decrease the procedure time both for the hospital system as well as for the patient care. The procedure time in the OR is around 3.5 hours, whereas in the TULA procedure, it's average about 33 minutes. Today, we're asking that you extend access to the TULA procedure. This will not add to the continuous cost right now. While we remove the facility cost and the anesthesiologist, it will only just allow patients to have access for the Medicaid population. And I'm going to hand it over to Dr. Ryan to speak about her patient experience.
Hi, I'm a pediatric ENT surgeon who places ear tubes both in the OR with general anesthesia as well as in office with TULA. And I've seen obvious advantages with TULA for many of my patients. And I want to highlight that two more of them that the other Marissa didn't already cover. One is that the FDA recommends minimizing exposure to general anesthetic in children, especially under age 3, because of unclear neurodevelopmental risks. And many of my patients on Medicaid have additional medical conditions that require other general anesthetics. So I particularly want to minimize additional exposures in this population. And then secondly, besides the fact that going to the OR creates really high medical costs, as surgeons, we are really quite limited in our OR time. Typically, patients can have TULA several weeks or even months sooner than waiting for the OR. And that means the child's feeling better, returning to daycare or school sooner, hearing better, and acquiring language sooner than if they had to wait for an OR slot. These benefits, as well as those mentioned by Marissa of TULA, apply to all children, but I think they could be particularly more impactful to my patients who are covered by Medicaid. And the patients who have had TULA have been very satisfied, and I would love to be able to offer this safe and effective option to all of my patients. Thank you.
Thank you.
Hello,
To Dr.
my
Schramm.
name is, thank you. My name is Jordan Schramm. I'm a practicing pediatric otolaryngologist as well. I am in Utah County. I just wanted to add my support to what has been said by the other three presenters for the TULA system. My clinical experience with TULA so far is 188 cases. Most of these, unfortunately, are only commercial payers or self-pay patients. I agree with all the benefits that have been highlighted by the other presenters. And I have a high proportion of Medicaid patients in my practice, and I would love to be able to offer the service to those patients as well. Thank you for your time.
Thank you, Dr. Schramm and Dr. Ryan, as well as Marissa and Megan. We appreciate your presentation. Next, let's go to Oreta.
Hi. Sorry, hold on.
Okay.
My name is Oreta Tupola. I'm the executive director with the Utah Community Health Worker Association. Next slide, please. Community health workers are frontline public health workers. They're trusted members of the community who represent the communities they serve. Their expertise is in lived experiences, but also are trained in different areas. If you remember, if you were on a MCAC in 2018, I presented with a plan and timeline of things that we were working on as the CHW coalition in the state to build the CHW workforce. And we have progressed a lot since then. Community health workers, community health worker is an umbrella term for dozens of paid and volunteer job titles, but they were a driving force in the public health workforce when COVID hit, in helping connect community members to resources, and continue to do by addressing social determinants of health. Next slide. This is just a timeline of the things that have progressed since the last time that I presented, going from a section to now an independent association. We are working very closely with community partners and organizations to help build the workforce. And in 2022, passed legislation for certification of CHWs, and now under the association are providing, launched the certification in December of 2023. This year, we're working on CEUs for this workforce, but also have about 600 CHWs across the state who have completed the core skills training and now are applying for certification. Next slide. This certification and this ask is to allow for reimbursement for CHWs that will add CHWs as authorized providers to deliver services to Medicaid members. Community health workers are a low-cost, essential contributor to the healthcare team. We have been effective in addressing COVID-19, high prevalence of chronic disease, mainly diabetes, and social determinants of health. This Medicaid reimbursement is essential for the sustainability of CHW programs, and it recognizes their value, supports improved health outcomes, and aligns with Medicaid goals of providing comprehensive care to underserved populations. Without reimbursement, unfortunately, CHW programs face significant financial challenges that threaten their ability to continue serving those who need them most. The average reimbursement, and this is done in other states, just an example for CH services is $17 per 30 minutes of education, and the state requires programs reporting CHW services in 30-minute increments with a maximum of 4 units per 24 hours and 24 units per calendar year. The maximum cost per member would be approximately $5,000 per year. And we are doing a lot of work to build evidence-based practice, specifically in Utah. There's a lot of national data that shows the effectiveness of CHWs, and the other states that have already implemented Medicaid reimbursement. Next slide. I want to thank you for your time and just say that CHWs just have been very effective, and on a national level, they are also working on support of this workforce through a CHW Access Act. But if you would like more information on the work of community health workers, especially here in Utah, you can visit our website at uchwa.org. Thank you.
Thank you very much for your presentation, Norita. That's very helpful. Next, let's move on to Mary Ann Neff.
Hi, I'm Mary Ann Neff. I am the owner of Northern Utah Case Management. I am one of 2 providers in the state of Utah that provides case management services for the EPASS program. And I can basically just mirror off of Dave Park's presentation. We were equally supported through the Social Services Committee this year and was not approved through the Executive Committee. This is, we've been presenting for a couple of years. So I just want to kind of give a current update with where the program is at. In the past, we've presented in terms of all of the case management services in terms of the direct care staff. I'm going to primarily focus on just the case management piece because I think that that is an important component. Right now, as I said, there's only 2 providers in the state that are offering services, and it's becoming increasingly difficult to find paid staff to fulfill this job. It requires a bachelor's degree. And at the current rate of $23.20 an hour, it's difficult to not only hire people, but impossible to pay any benefits or overhead costs in relation to that rate. We serve approximately 240 people across the state. Our company alone does about 100 of those individuals. And it's to our knowledge, there has not been a rate increase since 2006 when this program was implemented. Please be aware that if that number is incorrect, I'm going off of information from an employee that has been doing this for the 18-year duration, and she has let me know that the rate for case management has not increased in that time. So anything that is different in relation to that, please just take it into consideration for what we are requesting. Since our company opened up, we started over 6 years ago. In the last 5 years alone, we have seen a 70% reduction in case management companies because they cannot afford the employees. We do not cover travel reimbursement. It is only when you are in connection with the client that we can bill for Medicaid. Just to put into perspective with the Bureau of Labor Statistics, it sits case management at an average of $26.25 per hour, which is minus the benefits. And that's primarily where the concern is that the cost of living has not gone up to accommodate for that overage. Just to jump right ahead, we are asking for a 35% increase, which would place us at the cost of living adjustment according to the Bureau of Labor Statistics, which is 35% within the past 18 years of where that rate would sit. Can you go to the next section, please? We just have a quick graph demonstrating the rate of pay and how it is in relation to the cost of living and in relation to where the current rate sits. Additional areas of concern is that the majority of our clients are on DSPD's waiting list. Without this program in place, a lot of those individuals are going to place higher on that DSPD waiting list. So I know within the legislature, there's been a lot of talk about how can we support the waiting list. This is one program that can support the waiting list and offset that pressure. In addition to our rates, we are also asking consideration for the staffing rates, which on average, we are looking at about $13 an hour that our staff are being paid through provider agencies. And currently, as it stands within our company with 100 clients, we have absolutely no providers that will accept any new patients because they can no longer afford it and are going under in business. It has become a self-administered service program only. We have actually disenrolled individuals because they cannot find staff, even though they are eligible and even though they present with the need. They did not have the resources to be able to find their own staff, and no providers would accept their level of care. We are also asking that you consider all of the areas that EPAS encompasses, which is the fiscal agent, the assessor, the case manager, and also the clients with their direct care pay. So there are 4 different areas, not just the case management, that are all sitting well below the cost of inflation. I will just echo what Dave said before, that we are at a critical point with this program that without an increase, it is going to go under. And there's 2 options: either the program discontinues or it's brought in-house within the state. And even with the rates that are being paid, the state would have to increase the level of pay to be able to support it in-house for where it currently sits. Thank you.
Thank you, Marianne. I appreciate the presentation. Next, let's go to Braden Robinson on peer support services.
Hello, everyone. Thank you to the committee for allowing me to present today. My name is Braden Robinson. I'm a person in long-term recovery from a substance use disorder, as well as severe anxiety and depression. I'm a master's level social worker focused on systems level change, and I'm a peer specialist with 5 years experience in direct service roles, supervision, program management, and development, and now serve as the executive director of the Utah Peer Network. At UPN, we are committed to creating a statewide infrastructure of support and advocacy for the peer support workforce to improve and expand peer support access and quality of services. Next slide, please. Peer specialists are people in recovery using their lived experience to help others find recovery. Peer services have been shown to be effective for people experiencing mental health and substance use disorders, as well as physical health ailments and in various settings. There are also benefits for the peer specialists themselves and the overall healthcare system. Service recipients see improved social functioning and integration into society, spiritual and occupational wellness, as well as increased hope and empowerment for recovery. Peer specialists see therapeutic use of self-enhancing responsibility, increased well-being and professional confidence, and career development supporting sustained recovery. The system itself sees decreased hospitalization days and rates, reduced length of stay, decreases to health spending, higher treatment engagement and satisfaction, increased work capacity, and decreased reliance on many public welfare benefits. If you've ever found peace in someone sharing their experience with you so that you know you're not alone, then you have seen the value of peer support. Peer support combined with or as an alternative to other treatments and supports changes lives. Next slide, please. The literature on the peer workforce experience nationally is new and growing quickly, and the findings are in alignment with what we hear consistently statewide. Peer workers experience low pay compared to similar roles, causing high turnover and burnout, a lack of role clarity and definition in the workplace, poor supervision, and a general lack of understanding and respect for the value of the peer support role, which leads to poor implementation. Next slide, please. Nationwide and in Utah, we're experiencing a behavioral health workforce shortage that's touching many parts of our society, from overdose deaths to suicides to the general quality of life for people receiving services. The Utah Behavioral Health Master Plan was created by the Utah Hospital Association, the Kem Gardner Policy Institute, DHHS, and other key leaders to identify systems-level solutions. In this master plan, peer support is highlighted 57 times throughout the 68-page plan, and these leaders specifically call for increased reimbursement for certified peers, more funding, and a living wage. Peers are the quickest and easiest workforce to train in behavioral health, but are often poorly implemented with compensation that's inadequate for basic survival. Next slide, please. Currently, the living wage in Salt Lake County for a single adult with no kids is $22.67 and goes up into the 30s and 40s with kids. The current rough average for peer specialist pay is around $18 an hour. Most peer specialists thus must have second or third jobs or leave the field for more money after only a short time in the workforce to support their families. This increases burnout and turnover, and this places a hard cap on the skills of the workforce and the quality of the services that are offered. With the master plan's emphasis on peer support, I believe it is the best, most viable solution to the workforce shortage, but we need to invest financially in supporting peer specialists so they can stay and develop in the workforce. With the rate at its current level, it's not financially appealing to organizations to prioritize these services. Next slide, please. Our ask is for a 35% increase in code H0038 peer support services. This would bring it to $20.91 per 15 minutes, up from $15.49. Some basic calculations for a large behavioral health organization in Salt Lake City would result in a net increase of $57,000 per year. Next slide. Starting from the average of $18 per hour, this could amount to a $4 an hour increase for 7 full-time employees or 14 part-time employees, or 1 new full-time position or 2 new part-time positions at $24 per hour. This would significantly impact retention and service quality. As an example of that impact, 2 large organizations and 1 mid-sized organization said it would greatly improve their ability to serve their community, provide more and better services, and impact their ability to hire and retain peer workers. Next slide. In calculating the cost of Medicaid at the new rate of $20.91, this would be an additional $1.26 million per year, which would be offset by the reduced cost of the system, reduced turnover costs to organizations, and improved service quality. Next slide. For outcomes, UPN will continue to track pay data for fluctuations and changes to averages. We're also conducting a statewide peer workforce survey to gather information about the peer workforce experience in Utah. And to some, peer specialists are effective in mental health and substance use treatment, healthcare, and carceral settings, urban and especially rural, and fill a unique gap in the service continuum that not only improves client outcomes, but takes a huge weight off of other professionals and the system overall, increasing access to care, decreasing wait times, and alleviating the strains the shortage is causing. However, this vital workforce needs your support and investment to be a sustainable and viable solution. My call for this committee is to invest in this workforce as the most viable solution to the workforce shortage by prioritizing this reimbursement increase for peer services. Thank you.
Thank you, Braden. Okay, next we have Centauri. Are you okay? Just wanted to make sure you were still with us. Go ahead.
No, I'm here.
Please.
Perfect. Can you hear me?
Yes, we can.
Perfect. Yeah. Hello, everyone. This is Perry Miner, Chief of Staff at Evolved MD. Thank you for this opportunity to speak on behalf of our company. In lieu of a slide deck, I'm going to outline the main points of a recent letter we sent to members of this committee that you should have included in your materials and also could be seen on screen. Here at Evolved MD, we are reimagining healthcare by not just integrating, but embedding behavioral health professionals into primary care. We leverage the Psychiatric Collaborative Care Model, also known as COCM, that places a licensed master level clinician in a practice to work collaboratively with the primary care provider. This type of integrated care has been touted as the most effective solution at the federal level and is the most supported part of the current administration's mental health strategy. Integrated care, specifically COCM, is associated with improved clinical outcomes, increased patient satisfaction, decrease in overall cost of care, and reduction in provider burnout. The solution for Utah's neediest as it increases access, has leading clinical outcomes, and accounts for the well-being of both physical and mental health providers. In Utah, we are currently partnering with more than 300 primary care providers across 45 locations, from Ogden to Greater Salt Lake and down to Provo. We estimate that nearly 500,000 Utahns now have access to integrated care because of our work, with thousands of Medicaid patients being among them. I'm here because Utah consistently ranks at the bottom of the most mental health metrics, including most recently 46th out of all states, according to Mental Health America, for mental health prevalence versus access to care. And at a time when so many people are suffering, especially Medicaid members, this body reduced collaborative care rates by up to 9%, depending on CPT code, in summer of 2023, with Utah rates being among the lowest 10% nationally. These rates make providing collaborative care to Utah Medicaid members impossible to implement and to sustain. We're here to tell you that behavioral health integration is essentially dead at the state level unless there's thoughtful conversation on not just increasing rates on collaborative care CPT codes, but having a creative conversation on ways to make this work for all clinics and providers. Our company is here to help, but we need you to show us that you're serious about addressing this issue, because right now, Utah's most vulnerable will not have access to sometimes life-saving mental health care unless immediate action is taken. With that, we respectfully request Utah's Medicaid leadership and this committee to increase rates for this service immediately, and then work in the coming months to develop a long-term sustainable value-based strategy to adequately reimburse providers providing to the Medicaid population. Please note that specific data and proposed with your materials, and I thank you for your time.
Thank you. I appreciate you waiting and presenting. Okay, our final presentation is Rick Huffaker from mobile radiology services.
Hi, thank you for your time today and your consideration. Appreciate it. Yeah, I'm Rick Huffaker with Pacific Mobile Diagnostics, a mobile radiology imaging company. Next slide, please. We bring our services to the patient. So we provide X-ray services, EKG, ultrasound, and echocardiogram services. And primarily, we are going into nursing homes, assisted living facilities, and private residents. Next slide, please. So the need and benefit of mobile radiology in the community. Transporting patients to a hospital or clinic can be unsafe or very taxing for a variety of reasons, especially for critically ill patients and the senior population with health complications. In many cases, it can do more harm than good to transport these patients to the hospital for a variety of reasons. We can reduce the anxiety and stress of the residents due to transport and length of time of diagnosis, reduce the risk of infection. And there's just obvious safety risks associated with transporting these patients. We perform over 200 stat ordered exams per month, which if we did not would increase the need for ambulance services and the potential for hospitalization. So bringing diagnostic imaging directly to the bedside eliminates the risks associated with those transportations, and it also eliminates the need for staff in facilities to be tied up in transporting their patients, bring them up for the ability to tend to other residents and their needs. Next slide, please. So our service area is all up and down the Wasatch Front, covering from north Brigham City to Nephi, as well as in the southern Utah area, St. George and Cedar City and the surrounding areas. We serve about 93% of the market in relation to nursing home facilities, assisted living, and home health agencies. And we, in 2023, provided close to 16,000 X-ray and EKG exams on patients and a little over 3,000 ultrasound echocardiogram services. Next slide, please. So it's our understanding, and I could be wrong with this, but that Medicaid rates are generally about 80% of what the Medicare fee schedule is, and therefore that would be what we propose. Through the lookup tool for CPT codes, it indicates the last time there was a rate increase for CPT codes that we use was in 1987. So we feel we're long overdue for a rate increase, which will help us to provide better care. We provided a little over 1,500 exams for Medicaid patients in 2023. The average reimbursement rate that we get for providing these exams with Medicaid patients is $62.33, and our cost is $109.53. Next slide, please. We truly do love serving our community. PMD wants to serve our community for a long time. It was said earlier by somebody, and we are kind of in the same boat as far as we've decided that we want to serve our community, and we are taking a loss for providing services to these Medicaid patients, and that's a decision that we've made. But we would truly love and appreciate your consideration for supporting us financially to improve our care and services to those in need in our community. Thank you.
All right. Thank you, Rick. And thank you to all the presenters that we've heard from this afternoon. We appreciate your preparation and better educating us on these needs. So for the committee members, if you'll keep your notes and review the materials when we meet next month, then we will plan to prioritize these requests and make our collective recommendation to the department. With that, and acknowledging we're well past time, I will entertain a motion to adjourn. And okay, thank you, Jennifer. That's great. And we will just proceed with that motion and assume everybody agrees. So thank you all for your time today, and we'll see you next month.